when they offered me to go against this debate, I really was a little surprised because I have always defended the contrary. But, sometimes you just need to go on the other side to look into different other options. So as I was mentioned, after the MonarchE trial was published, of course, we have stopped doing axillary lymph node dissection in patients with 1 or 2 positive sentinel nodes because we already have enough data with a follow-up of more than 10 years that the oncologic outcomes are the same, whether the patients undergo an axillary lymph node dissection or not. And if I may say, the breast surgeons are the ones who really see the morbidity of the axillary lymph node dissection and the axillary radiation therapy. So we see our patients with this lymphedema that, it's a chronic morbidity for the patients. So we very much, put into the clinical practice avoiding an axillary lymph node dissection in this patient. It's true that if a systemic treatment on a patient will improve their survival or their disease-free survival, and it depends in very selected patients on the number of positive lymph nodes. If you just if the patient do not comply because of the tumor size or the grade or something, and the only thing that they need to know is the positive nodes, how many positive nodes or more than 3 or 4 positive nodes, then in those cases, I think that the patient will benefit more. And we have other types of surgery that we can do to prevent the lymphedema. So we can do the arm reverse mapping. So I think that we can discuss those patients, and I'm against to say, no, we are not doing an axillary lymph node dissection no matter what. I'm open to discuss the cases where the patient will benefit because we have other technical surgeries that we can do to decrease the lymphedema.